Okay, thanks. Without any further waste of time, let me hand it over to you, Dr. Anne, for your presentation, please.
Can you see my screen?
Yes.
It's perfect.
Okay, great. So thanks, Khalid, and good evening, everyone from Botswana. As it gets colder in Canada, it's getting hotter here. So I'm giving this talk today on behalf of many colleagues, and the slide mentions some of them and their affiliated organizations. Our partners in Bauchi State, Nigeria, have been pivotal to the work I'm going to present today. And I'm hoping that one or two of them might be able to join us this evening. And that's particularly in an NGO, FOMWAN, Federation of Muslim Women Associations in Nigeria, and Bauchi State Primary Healthcare Development Agency. Also working with us in Bauchi, it's an international group of CIET colleagues. And also, of course, in the last 7 years or so, Participatory Research at McGill, led by Dr. Neil Anderson. And I want to say that Professor Anderson conceptualized the participatory research in Nigeria, including the work on men's engagement in reproductive health. And he remains a key resource for and an advisor for the ongoing work. This is a narrative from one of the men who participated in the work that I'm going to describe. I like it because to me it encapsulates how he feels happy with his new knowledge, and he feels empowered to care for, and even to care for his wife, and even to advise others. And for me, it's a far cry from the idea that men don't want to be involved in maternal and health and child health matters. It's widely recommended that men should be involved in reproductive health. And in 2015, the World Health Organization included promotion of involvement of men as one of their strong recommendations for interventions for maternal and newborn health. Interestingly, they did this with caveats. The first caveat was that these interventions should be such that they respect women's choices and autonomy, because recognizing that there was a risk that more engagement of men or more involvement of men may simply strengthen the entrenched gender inequalities. So that was their first caveat. The second caveat was, although they were making this a strong recommendation, the quality of evidence for the benefits of engaging men was very low. So what is the evidence about male involvement in reproductive health in particular? Well, there've been a number of systematic reviews about this, and what I'm going to do in this slide is really to just very much condense what the different reviews have said. There've been a number of different interventions that have been tried to increase male involvement, including media campaigns, community meetings, visits from community health workers, workplace initiatives, couples counselling. So quite a number of different interventions intended to increase male involvement. In terms of what they measured as the outcome of these studies, or I should say most of the studies are cross-sectional studies, very few of them are trials. Such studies that have been done have mainly used as an outcome increased women's use of maternity care services like antenatal care, facilities, births, after birth care, and so on. So that's often been the outcome, and many of the studies have reported an increased use of women's use of maternity services has increased with these interventions. Some of them have used male attendance at antenatal care with a partner as an outcome of the intervention to increase male involvement. And they've similarly also associated that with further increase in women's use of services. This is quite interesting because in at least one one or two studies, it spawned a little cottage industry, because if women one of the ways they tried to get men to come to antenatal care was that if a woman turned up with her partner, they would get certain benefits or incentives and so on. So there was a little cottage industry of men who would be there to accompany women whose partners wouldn't come with them, so that they could get those benefits. So it doesn't always work out the way you hope it will. A lot of the studies reported women's reports of partner behavior rather than the actual partner behavior itself. They relied on women's reports about that. Some of them have looked at men's knowledge and attitudes and behaviors, and the results have been a bit mixed. Some showed increases, other types of intervention didn't. There's a big gap. Very few of the studies had looked at maternal and child health outcomes. They used these proxy outcomes of more women attending services or more men going with them. So I'm going to talk about our work in Nigeria, but a few words about the Nigeria context. First of all, Nigeria is one of the countries with the highest maternal mortality in the world. It hasn't got the highest maternal mortality ratio in the world. It's still enormously high at 814 per 100,000 live births. But because the population of Nigeria is so big, it results in a huge number of preventable maternal deaths in childbirth and in and around childbirth every year. So most of the work I'm going to be talking about has taken place in Bauchi State, and this just shows you where Bauchi is. It's in northeast Nigeria. It's got a population of about 5 million. 95% of them are Muslim. It has indicators of health and socioeconomic indicators worse than most of the country. Only 26% of women aged 15 to 49 are literate. The maternal mortality in Bauchi, such information as we have, is even higher than the already horribly high national rate. And the rate of pregnancy amongst adolescent girls is also quite high, and of course with the high risks associated with that. There's some evidence about use of antenatal care. I'm not going to share a huge amount about this, but just to say that in Nigeria, this comes from the most recent Nigeria Multiple Indicator Cluster Survey, the 2021 version. Overall in Nigeria, about 70% of women attend for at least one antenatal care visit. In Bauchi, it's less than half. Maybe that isn't such an issue when you consider that among women who do attend for antenatal care, there's been some work looking at whether they receive the minimal acceptable quality of antenatal care against a number of things that they're supposed to have, like measuring blood pressure, et cetera, et cetera. It's only about 1 in 10 people, pregnant women who go for antenatal care, who get the minimum acceptable quality of antenatal care. So something needs to be done to try to see how one could look at maternal health or improve maternal health, even in the absence of being able to go to decent antenatal care. So I'm going to just give you some overview of our engagement, our work on engagement of men in Bauchi. It began really around almost 15 years ago now, and it's continued over a number of different project names and different funding partners, but basically the same work, the same team, but funded under different umbrellas. The first project was under the Nigeria Evidence-Based Health Systems Initiative. That was between 2009 and 2014. And towards the end of that, in 2012 to 2014, we piloted the home visits in Giade. And then sorry, let me go back. Oops. The more recent home visits project that I'm going to be talking about was under the Innovating for Maternal and Child Health in Africa initiative. So what's the evidence about maternal health in Bauchi? Under the NESI project, CIET undertook several rounds of surveys and focus groups looking at issues that the Department of Health, the Ministry of Health in Bauchi prioritized, and they prioritized maternal health and child health, early child health as their issues. So we had a surveys of household surveys and focus groups in 90 communities and household surveys covering almost 8,000 women pregnant in the last 3 years. And what we found was that there were, of course, this is cross-sectional, so these were associations. We found there were associations between certain risk factors and poorer maternal health, complications in pregnancy and childbirth. Domestic violence, experience of domestic violence, continuing heavy work in pregnancy, lack of spousal communication about pregnancy and childbirth, and lack of knowledge of danger signs. Now, importantly, all of these things are something that they're under male control. There's something that men should be involved in and could be involved in and could improve these risk factors. So the survey, the study that reports this, I mentioned it at the bottom, and I don't know if we'll be sending around the thing, but I don't know if people will be able to click on the link to be, anyway. Perhaps when it's recorded, the people will be able to click on that link to see the actual paper. So as part of this earlier work, the NESI work, we recognized, okay, so maternal health is a problem. The health services, the antenatal care services and so on, couldn't even cope if you tried to get more people to visit them. So what could be done to try to help households help themselves to improve maternal health? And in particular, what could we do to help men to make decisions to improve maternal health? So we decided to pilot universal home visits in one of the LGA's, local government authorities in Bauchi State. This is a graph of Bauchi State and Giade local government authority. So what we learned from the pilot first was that, yes, it was feasible to visit all pregnant women and their spouses in an area. When we talked about these home visits, they're universal. Nobody gets left behind, because obviously with antenatal care, one of the problems is the people who most need it are the ones who are least able to get it. So this was overcoming that problem. And we established the feasibility. Something like 27,000 households and 8,000 pregnant women visited per year in this pilot. And we also tested the infrastructure. We started off with paper records and moved on to electronic data collection. It was promising. There was an indication that this could have an impact. I've said here MMR because basically it was the number of deaths compared with the number of live births, and that still horribly high, but there was some suggestion that over the 3 years it was reducing. And Giade, compared with the rest of Bauchi State, the women had better knowledge of danger signs. They were more likely to reduce heavy work, less likely to suffer partner violence, and had less complications of pregnancy and birth. This was not all significant, of course, because these were relatively small numbers, but it was in the right direction. So that encouraged us. So then we embarked on this trial of universal home visits in Toro local government authority. And the protocol for that is here on the slide. You can access the link. So Toro local government authority is much bigger than Giade. In fact, it's the biggest LGA in the country, I think. This was our theory of change behind the home visits. The idea is that home visits to pregnant women and their male partners can have an effect on their attitudes and allow them to take actions which would address the identified risk factors, and in so doing, improve the maternal health outcomes. I'm going to mention this Cascada. This is it's a a behavior change model based on the theory of planned behavior. And there are a number of intermediate steps starting with conscious knowledge, in this case, knowledge about the risk factors, attitudes to pregnancy and childbirth, and perhaps to women's work during pregnancy and childbirth, deviation from subjective norms for behavior and gender norms, for example, intention to change, agency to change, discussion, and finally action towards safer pregnancy behaviors. So that was our theory of change that we were testing with the trial. It was a stepped wedge cluster randomized controlled trial, and this is a schematic which just shows we randomly allocated the wards. A ward is 3,000 to 10,000 household. We randomly allocated pairs of wards to 4 waves. The wave 1 wards got their visits starting immediately. Wave 2 wards started after 1 year. Wave 3 wards started after 1 further year. And wave 4 wards, we just had their baseline data. So we compared at the end of the first year, wave 1 wards having had the visits with wave 2 wards that hadn't yet had the visits. And similarly, wave 2 with wave 3 and wave 3 with wave 4. So that was the design of the trial. So the home visitors were in pairs of a man and a woman, and they had about 300 households catchment areas. And the woman home visitor visited all households about once a month, identified pregnant women, and then followed up the pregnant women every 2 months during the pregnancy, and shared with them evidence about the risk factors, the local risk factors that we had identified. The male home visitors visited the spouses of the pregnant women also every 2 months and shared the same evidence with them. They either just shared the evidence verbally, or they used video clips on handheld devices to show the evidence. So the evidence about maternal health that they shared was those 4 risk factors I mentioned: domestic violence, heavy work in pregnancy, lack of spousal communication, lack of knowledge of danger signs. They didn't tell households what to do. They shared the evidence. And they said to them, what could you do about this? Essentially, they said to them, what could you do about this in this household? And then on subsequent visits, they asked them, what have you done about this in this household since I last visited? And similarly, for infant health, we were particularly targeting household hygiene as a preventive factor for childhood diarrhea, management of diarrhea, breastfeeding and immunization. And again, what could you do about this in this household? What have you done about it since last time? But what the households actually did was their choice. So just to give you an idea of the scope, we visited about 36,000 households in 6 wards and registered about 25,000 newly pregnant women. And overall, it was about 69,000 visits to pregnant women and their spouses with the follow-up visits. And we collected information on more than 12,000 completed pregnancies and follow-up information on children born from those pregnancies once they were 12 to 18 months old. And it was about 2,600 children who reached that stage. I want to share I don't know if this is going to work. I want to share with you a little extract from one of the video clips that they showed.
Allah a cikin kowaɗanne mata 20, mata 3 a ƙaramar hukumar Toro suna fuskantar matsanancin hali kamar sauran mazaje da ke ƙaramar hukumar Toro. Shi mai gina Fatima a sani fa rai dan igore ban ruwa ke so.
We added the translation. Of course, the videos were in Hausa. The docudramas, soap operas are very popular there. So it was in the style of a soap opera. So first is that the home visits made a difference to, in this case, I'm showing you the findings about maternal health. We compared women in visited wards with women in control wards. And we found fewer complications in pregnancy, significantly fewer complications in pregnancy. For example, swelling of hands and face was less in women in the visited wards. And actually it was quite a big effect. The NNT, you only needed to have the visit for women to prevent one case. So this is a strong effect. And less infections after birth as well, sepsis within 6 weeks with an NNT of 3. So strong effect. And this is the write-up of this is available in BMJ Global Health. We of course, our idea was that we would be targeting certain risk factors. And so we measured whether they were less in the visited wards compared with the non-visited wards, and they were. There was less domestic, women in visited wards experienced less domestic violence, less heavy work in pregnancy. They reported better spousal communication, and they had better knowledge of danger signs in pregnancy and childbirth. So we were pleased to see that it affected the things that we were targeting. So remembering the theory of change, our idea was that it would be making these differences in these behaviours, these household behaviours, that would improve the maternal outcomes. So this is our sort of hypothesized mechanism of impact of the visits on maternal health. They were associated, that the trial showed that there was improved maternal outcomes. What we didn't find was that women in the visited wards made more use of health services. They didn't. There were not more antenatal care visits. There were not more facility births. What there was, as I mentioned, a decrease in these risk factors. And specifically, these risk factors, if you remember, were things that were within male control. So changing those risk factors, those male controlled risk factors, seems to be what improved the maternal outcomes. And in fact, we did some specific analysis, and even though we'd taken into account the non-significant changes in use of health services, they didn't explain the impact. So coming to child health, we compared children 12 to 18 months resulting from pregnancies in the visited wards compared with those in recent pregnancies in the non-visited wards. And again, we found quite important impacts. There was less diarrhea these were all significant. There was less diarrhea in children in the visited wards with an odds ratio of 0.4. There was better diarrhea management. They're more likely to have increased fluids and continued feeding. The mothers had a better knowledge of how hygiene was related to the risk of diarrhea. And there was better observed hygiene in the homes. The interviewers looked at the hygiene. So this is, again, has been written up in BMC Health Services research. Then coming to, we did look directly at the impact of the home visits on men. So we compared the men, the spouses of the pregnant women in the visited wards and the non-visited wards. And indeed, they did have better knowledge. They were more likely to know four danger signs in pregnancy. And here again, quite low NNTs, an NNT of 6. They know the management, more likely to know the correct management of childhood diarrhea. They had better attitudes, so that they were more likely to believe that women should reduce heavy work before the 3rd trimester. And they had better actions. They were more likely to report discussing pregnancy and childbirth with the spouse. And again, this is written up in Journal of Global Health. One question we were interested in is which men changed their knowledge or attitudes. Was it more educated men? Was it men from more more urban communities or more rural communities. We were able to look at this because we measured these things on several occasions when we visited the men more than once. So for some men, we were able to look at this in the visited wards. Of course, the scope for positive change depends on the initial level of knowledge or attitudes. If it's already very high, then there's not much scope for improvement. There's a possibility of negative change, but we saw hardly any of that. So what we were able to analyze is men who didn't have knowledge or a positive attitude on the first visit. What were the things that were associated with them improving? So getting more knowledge or getting a better attitude. And we did not find any consistent associations between personal and socioeconomic characteristics and positive change. So a man with no education was as likely to change his attitude or behavior as a man who had much better education or a higher income. So, but there's more work to be done in terms of teasing out what would be the characteristics or which men respond better to these home visits. But so far we haven't found any particular pattern. To try and look a bit more about the way these the home visits affected people, the sort of the mechanisms, if you like, we collected narratives of change, drawing on the most significant change technique. So this is impact as perceived by the participants. And we conducted a deductive thematic analysis using the Cascada model as our framework. And we also did some additional gender analysis. And there's 2 papers about those analyses that are mentioned. So I'm just going to go quickly through these next slides. I'm not going to read out the quote. I'm going to say it to myself silently to give you guys time to read it for yourselves. So I'm going to go through each step of the Cascada. So this is conscious knowledge, and many people told us about changes in conscious knowledge. So this was a 27-year-old man. Then we looked at attitudes. A 58-year-old man describes how he was forced to change his attitude. He felt that after the visits, he really had to change his attitude. So I find the subjective norms quite interesting because they're quite strong, the subjective norms about certain kinds of behavior and what's expected and so on. And a number of people told us that as a result of these home visits, they had come to think differently and to go against, to deviate from these subjective norms. This was one around violence and going against expectations. Intention to change was interesting because the way we timed the collection of the stories, most of the people who were giving us stories had already made changes. It was towards the end of the household visits in one of the waves. So not that many people talked about intention to change. They more described changes they'd made, but a few of them talked about the intention to immunize and so on. Agency, to me, this is one of the key findings that we talk about agency for women, but to me, this is showing agency amongst the men, and it was many of them described to us how they now felt empowered to be able to get involved in caring for their wives during pregnancy. They understood what they needed to do. They had the knowledge now. In the Cascada model, discussion is very important. It's the step immediately before action. And so many people talk to us about discussing and sharing ideas with their wives. Many men describe that as something that had happened to them as a result of the home visits, the visits to the wife and the husband. They both had the same information talked about, and they started talking to one another about it. a lot of people talked about actions and described their actions actively, and many of them went on to say, yes, I did this and look, it worked. Sometimes perhaps their perceptions were a little bit rosy, but they definitely not only took action, but were happy with the action that they had taken. So we did some more analysis looking at, to what extent could we say that these home visits were gender transformative? And this diagram I've taken based on an article by Pedersen et al. And transformative talks about addressing causes of gender-based inequalities and work to transform harmful gender norms, roles, and relations. Now, of course, it would probably be unrealistic to think that just with these few home visits, we're going to change long-lasting, entrenched gender norms. But I think we did have some evidence that there was some move towards that, and I'll show you. So for division of labour, yeah, there was a difference in division of labour, but it didn't necessarily reflect a change in who made the decisions about that. Here's a story from a 30-year-old man. So yes, a change in division of labour, but maybe not reflecting changes in decision-making. And then decision-making around the use of health services. This is a woman who describes a change in being able to use health services to immunize their children. But she's still talking about the fact that the husband is allowing her to take the children to be immunized, implying that he's still the gatekeeper. Probably the most encouraging sign was this increased discussion. And it really did suggest that in some cases, there was some joint decision-making going on. So just to pose the question, really, are there lessons here for Montreal and Canada? Perhaps this is something we can talk about in the discussion period. But I do think that there are some south-north lessons here. I know we usually say, oh, well, it's relevant for Montreal because we have immigrant populations. But I think it goes beyond that. I think this is to do with the medicalization of maternal, of reproductive health and maternal care. And I don't know how many men in everywhere would have felt a little bit sidelined. They don't know about this. It's a medical thing. They don't have medical knowledge. They don't feel that they're in a position to take action to help matters. And that was certainly true in Bauchi, and it can be reversed. So perhaps there are some lessons for Montreal and Canada going beyond, well, this is relevant to the immigrant populations. So I just want to finish by, again, thanking everybody the many people who are involved in this work over the years, and also the funding bodies that were involved. Thank you.
Thank you. This was a great presentation.
Thanks,
So,
Alexandra.
If nobody has a question,
Khaled, you're muted.
Yeah.
Sorry
There
about
we are.
that. Yes. Thanks, Dr. Ann, for a wonderful presentation. I think this was a big reminder for me being a member of that team. It took me to the dynamics of what we were doing at that time and the wonderful experiences and outcomes especially. So thanks a lot. Wonderful. Let's check if we have some questions or comments about the presentation.
I think
So
I see two hands up.
Yeah, I raised my hand. I see Jeannie. And there's
Yes. Please go ahead.
I'll just go with a quick one then. You kind of mentioned that, okay, well, men were empowered now in the process, and there's something a bit odd, right, to hear like, oh, finally men are empowered and to do this. Did you hear, and you mentioned that you didn't really see clear negative impact, but was there anecdotes of potential negative impact of this empowerment, and now they were more in a position, certain men could have felt more in position to actually have power over what's going on in a negative way?
It was something we were very much aware of course. And but the interesting thing is, well, I suppose empowerment's a funny word, isn't it? Maybe I should talk about agency rather than empowerment. Men already have a lot of power there, but they don't have the knowledge. So, you know, they extract themselves from the thing by saying, you know, that's, you know, I don't know about that. That's what my wife does. And maybe they have some attitude about, you know, she doesn't go. They really felt, you know, this, they really felt, now that I know how to look after my wife, I can do it. I don't have to rely on her going to the clinic, because the clinic is often closed and so on. So there's something I can do myself to help my wife. And, you know, there was a very positive thing from that. So we didn't have any cases of women saying, oh, you know, because you involved my husband, it made things worse. Not at all. It was quite the opposite. And I think it was because they shared the same evidence between them. And so that they often then had a shared platform for discussing with one another.
That's amazing work. I'll let others ask questions.
Yes. Janie, you have a question, yes?
Yeah, yes, thank you so much. And I definitely echo that this is amazing work. And other than the fact that I'm suffering from severe publication envy, and just at your capacity to do, you know, something that is so powerful, it's really amazing. Just in terms of, it's a comment a little bit on the previous question, but, you know, it's interesting because it now becomes power to empower as opposed to power to control. That's kind of like when you were suggesting that, it felt like a kind of shift in what the power was used for. So that was really interesting. My question is actually, what happened after? Like, then what?
Yeah, thank you. That's I didn't have time to put that in, but it's a really important part of it. One of the things we were trying to do was to say, okay, this is a trial, this is a research, but we'd like this to happen on a much wider scale. So we did a number of things to help with that. We had government officers who joined the team, and they were part of the team. And in fact, in the first wave wards in year 3, they took over management of the program in that ward, in that wave. And we also had some very detailed training for government officers to manage the home visits program, so that it could be, when rolled out into the rest of the state, there would be a kind of a critical mass of people who knew how to do it, and how to manage it. And the Primary Healthcare Development Agency said, yes, we want to do it. And we worked with them on a plan for scaling up and all the rest of it. And they still want to do it. And they got their budget agreed, and it was there. And then, of course, a budget agreed and the budget money actually getting there. They're two different things in Nigeria. So we haven't given up that it will be extended statewide. And it's certainly, it's the state official policy that it is going to be. But there's a funding issue, and there's elections coming up next year. So those are the realities. But yeah, we went quite a long way towards scale up and institutionalization.
Congratulations again.
Thank you.
Thanks, Jeannie.
We have a question from Menika.
Good morning, good afternoon, everyone.
Hi, Menika.
Yeah, Dr. Anne and your team, I'm really, happy to see this kind of research going on in in Nigeria. I'm actually from Nigeria, and I can imagine it looks very well written, but I can imagine the back, the stress and, a lot of work must have gone into this to get, everyone on deck. I do have a few questions. One of them is, I noticed that most of the quotes that you posted seem to be very positive. And then another thing I noticed was that most of the men who spoke had one wife. Now in Bauchi State, I know polygamy. Bauchi State is in the north, and there are also Muslims from what you said. There's a lot of polygamy. A man can marry up to 4 wives. So I'm trying to see how practical it is, maybe for a man to follow his 4 wives to antenatal care. And these are women that are going to have 4, 5 children or more, minimum. It seems a lot of work for them. And I'm just trying to see how practical it would be for people who have, more than 1 wife to keep up with, the things you're trying to do. I don't know if you came across any challenge in this while you were trying to do this. You tried to talk about, seeing the difference in men who accepted the intervention. You looked at education. I'm wondering if men who were polygamous kind of resisted, because I don't know, for me, I'm just wondering how practical it would be for them. Thank you.
Thanks. The first one, yes, many of the stories were positive. This is a feature of most significant change stories. They tend to be, even though you say you can give us negative stories as well. What it's really saying is, it's not saying, is it always a positive effect? It's saying, how do people experience it? What's the sort of possibilities for, when it works, how can it work? And what does it do for people? It's a well-recognized issue about most significant change. You tend to get positive stories. We know that. That's fine, because you're not trying to, it's not a quantitative issue. Polygamy, I'm surprised actually, because we had a lot of answers from polygamous men, and maybe I didn't write the things underneath the things properly. Many of them had more than 1 wife. And we looked at polygamy as to whether that was one of the reasons why there was change or not change in the men. It wasn't. The polygamous men were as likely to change as the non-polygamous men. And I should say that it's not a question of following their wife to their health facilities. It was more about doing something in the household. So that's the same whether it's a polygamous household or a monogamous household. So yes, many of the households were polygamous for sure.
Okay.
Thank you.
Ella, you have a...
So not really a question, but sort of more an observation. This is absolutely fascinating work. And I think what is interesting to me is sort of the modalities of behavior change you used, Anne, in this work. And the one observation relates to the fact that you presented evidence and got people to figure out their own solutions for their own particular context. I think that's very powerful, because so often we tell people what to do with no realization of the constraints, they experience or on a regular basis, and their inability necessarily to affect the good practices that we should advise them to put in place. So I think that's a super powerful sort of approach that needs to be thought through and perhaps implemented more widely as a behavior change communication strategy. And I think the fact also that it engendered dialogue between the couple is also incredibly powerful. So just to signal how amazing that is, and we need to reflect on that more. And the other thing that I wanted to comment on, and this is, and I'm thinking about things with respect to Canada. How is this, relevant to Canada? And the other thing is really the power of the home visit. We've forgotten about the home visit in Canada, I think, to a large extent, but that sort of opportunity to have, a time with a healthcare provider, a community health worker, one-on-one, and what that visit engendered in terms of agency and change practices is remarkable. And the fact that your effects were there and had nothing to do with the healthcare system whatsoever, right? So you had positive health outcomes, and that wasn't due to engagement with the healthcare system. So again, something I think which is really powerful, which is, you know, there's so much around health that can happen, you know, within the context of the household. And so again, something we need to think through a little bit more, I think, on this side of the pond.
Thanks, Elena. One thing I would also say is that I think one of the things that I didn't really stress so much today is it was the repeated nature of the visits. The fact that they didn't just go once, they kept coming back. And even some of the men and women said to us, you know, the first time they came, I just thought, okay, all right. But then they came back and they saw me again. And they said, well, what are you doing about it since last time? And it was just that idea of accompaniment that really, really helped a lot. So it was the home visits, yes, but the repeated nature of those visits really helped. I should say about the health services, one of the things that it wasn't very easy to measure, but one of the things that I think happened was that although not more people used antenatal care, women did go, or they did go when they needed to go. So when there was when they were aware of a danger sign or whatever, we've got some quotes. You know, one man said, "Yes, even just this morning, I sent my wife because I thought she was complaining of headaches or something. I looked and I said, yes, you have to go to the clinic." So it was that, you know, appropriate use of services and being and again feeling able to decide for yourself. Okay, now I know enough. I need to go and get checked. So not to ignore services altogether, but not to just be kind of going on a routine basis.
Alexandra, you have to say something?
Yes, I have more. I could go on forever. But I have a question on the knowledge sharer, the people you train. So kind of two questions related to that. I mean, this is a huge project, and I'm so impressed at the number of visits that were conducted. And I can guess that the training, the hiring, the training, you know, a lot of resource must have been put in keeping and training the shared trainer. So two questions about that. And do you think that it could be doable to show an economic benefit of it, given the benefits in health as women? And second, were you able to size or collect, or are you planning to collect any benefit in the knowledge sharer themselves, like in the experience of doing this?
Yeah, thanks. It was quite a task to get the home visitors. We had hoped to use what they call the junior CHOOS, community health extension workers, but actually they didn't work out. It was very difficult. Many of them are actually the only person in the health facility, so they don't have the ability to be going out into the community. So in the end, we started using people who had much less education. They were selected by their own communities. So the community leader would recommend who we should train from that community. We had to change our training. We extended it a little bit because we had to sort of go back and, you know, make it longer because they had less basic education. It was much better for them, particularly for the women. I mean, Bauchi is not a very secure place, and traveling between communities is a bit tricky. But if you're from that community, it's easier. So we trained them from within those communities. Yeah, we did work out a bit about the economic costs of it, and it worked for not for the research bits, but for the other bits. It was less than $1 for the visit to the woman and the man. So not expensive. We did ask the people themselves, the visitors themselves, what difference it made to them. It made a big difference. It's written up actually as part of the MSc paper, and they found it increased their confidence, it increased their feeling of worth in their community. Of course, it increased their own knowledge, but their sort of self-esteem, that now they could talk to different people in the community. So it had broad effects on them. And of course, the women particularly talked about it had economic benefits for them. So, even, the small amount of money that they got for this helped them this was not free. I mean, they were paid, the workers. This is not something that they're expected to do, but they were paid by the visits. So depending on how many visits you did, you were paid accordingly.
And do you think it had a kind of snowball effect beyond what you measured? Like, one could expect that even the participants, the women receiving the information, could have spoken to their sisters, their family.
Oh, yes.
Around, their
definitely.
neighbors,
Absolutely.
beyond what you measured.
Absolutely. Definitely. Yeah.
So interesting.
Okay. I think we have exhausted the question. Anybody else who has any question or comment? And I think we are reaching close to our time as well. So let me just take this opportunity to thank everyone, especially Dr. Anne, for a wonderful presentation, to all our participants for their attendance and contribution for the discussion, and to our organizers as well, the host, Dr. Alexandra and Alexandru, for the management part of it, to make this seminar happen. Just before we close, I would just like to make an announcement for the next seminar. The next seminar is on Friday, November 4th, 2022 at the same time. And Dr. Michelle Griever, Associate Professor from Department of Family and Community Medicine at University of Toronto, will make a presentation on Utopian, the University of Toronto practice-based research network. So don't forget to join us for our next seminar. So once again, thank you very much, everybody, for joining us today. Wonderful. And from my side, it's goodbye till we meet again on our next seminar.
Thank you, Kelly.
Thanks.
Thank you, Anne.
Thanks a lot.
Thanks.
Bye.